Good
Good
morning,
morning.
Dr. Sawari. How are you?
I am all right. How are you doing?
I'm good.
Good,
I'm
good,
good.
good. Is the voice coming across okay? Voice check's
Yeah.
fine.
Yep, sounds great.
Very, very good. Appreciate all the heads up and all the information and notices. I thought I saw we don't have grand rounds next week. Is that correct?
Correct. Yes.
Okay.
I think there's a virtual like ACP.
Oh, that's right.
Like,
Oh. Randy, do you mind if I check to see if you can see my slides?
yeah, you can go ahead and share your screen.
Coming across okay?
Yes.
Let me just do that, make sure I can swap that. Okay,
Perfect.
very good. I'm going to go incognito here for a while, okay?
Okay, that's fine.
All right.
Good morning, everyone. Welcome to this week's Medicine Grand Rounds. Just a few reminders for those of you joining remotely. Please make sure your mics are muted today to avoid any unintended interruptions for our speaker. Please ensure your full name is on your Zoom login so you can be easily identified. And if you're logged in as a group, please email Department of Medicine Grand Rounds at hsc.wvu.edu to receive credit for today's lecture. If you have not participated and received credit for Grand Rounds via Zoom before, please complete the credit request form located in the chat box during the Zoom lecture. We will save time for Q&A at the end, and if you type your questions in the chat, I will work to relay those questions to our speaker. We will try to wrap up around 8:55 in order to get back to our clinical duties. With that, we welcome Dr. Sawari. Dr. Sawari attended medical school at Aga Khan Medical College and graduated in 1990. He then joined us here at WVU for internal medicine residency. He completed his fellowship in infectious diseases at the University of Maryland, as well as completing a master's in science, epidemiology, and preventative medicine. Luckily for us, he returned to WVU in 2000. He most recently completed a master's in business administration at WVU in 2011. He has worked tirelessly in the development of the HIV program and Ryan White Clinic here at WVU and has received many grants to fund his work in the department. He is an outstanding teacher for all of our medical students, residents, and fellows, and has a remarkable way of teaching that captivates you from the second he starts a lecture. With that, everyone, please join me in welcoming Dr. Sawari.
Thank you very much, Dr. Shannon, for the kind introduction. This has been an interesting journey over the past few years. This is my 12th Grand Rounds to the Department of Medicine since returning, and it's the first that is a pure reflection piece. So most traditional Grand Rounds have cases and review of literature. This one is much more of a reflection piece. I'm going to go ahead and share my slides with you here. My hope was that I would get a chance to do this Grand Rounds in person. So obviously that hasn't happened. So I do have a very specific request in terms of how I would like you to view this Grand Rounds. If you go to your top right-hand corner and click on the grid and use speaker view, and if you humor me by allowing me to be at least 1/3 the size of your screen, I would like to feel like I'm communicating very directly with you. I would certainly appreciate that. So why look at these two pandemics? Mainly because they have very much influenced my understanding of infectious diseases, but from two very different vantage points. For me, the HIV pandemic was something I learned about as a medical student, saw my first patient at West Virginia University as a second-year resident, learned more about it during my fellowship, and then had the opportunity to develop programmatically the Ryan White Clinic here at WVU. My vantage point for the COVID-19 pandemic was very different. I had a significant administrative role in the Department of Medicine, which I knew was going to bear the brunt of the care delivery for a brand new disease model that we had to quickly understand and pivot and work together so that we could provide the care that was needed to our patients. My specific objective is to compare and contrast the two major pandemics of the last 50 years. I do not have any financial disclosures. Let me start with a statement from Tony Fauci. He wrote, "I don't think any of us could have possibly imagined in our wildest dreams how this would have exploded the way it did. We have been living through one of the most important catastrophic public health events in the history of civilization." Now, most of you will think he's talking about COVID-19. This is a statement from 2006. when he wrote an editorial piece in the New England Journal of Medicine, recognizing 25 years of the HIV/AIDS pandemic. That's why I'm comparing these two. So we'll start off with basics and rapidly escalate up to topics that would be pertinent in terms of a deep dive. We know that the virus, human immunodeficiency virus, causes the disease acquired immunodeficiency syndrome, or AIDS, just as the severe acute respiratory syndrome coronavirus 2 causes the disease COVID-19. Similarly, we know that the first case of HIV was identified in 1981 and published in the MMWR. These were small series of 5-6 cases of Kaposi sarcoma and pneumocystis pneumonia in the large metropolitan cities. COVID-19 was first identified in Wuhan, China in late 2019, November, December. Both diseases have their origins as zoonotic infections. Zoonoses meaning a virus that exists in an animal reservoir and then gets transferred over to the human population. HIV started as an African zoonosis, where the virus simian immunodeficiency virus, or SIV, jumped species to the human population. The earliest identified cases are from the 1950s from the Congo. It is not until the 60s and 70s, when the mining industry boomed in central Congo, that more and more cases occurred and eventually spread all across the world. Similarly, COVID-19 started as an Asian zoonosis. We know the beta coronaviruses, which are prevalent in bats, periodically can jump species, and through an intermediary like the pangolin, identified as a potential intermediate species in Asia, transferred to humans, and subsequently from there to the rest of the world. Both viruses are large enveloped viruses. HIV has glycoprotein receptors on its surfaces. The GP160 molecule on the HIV virion interacts with the CD4 receptor and the chemokine co-receptor to gain entry into CD4 positive cells. CD4 positive cells are diffusely distributed throughout the body and include our lymphocytes, our macrophages, our monocytes, microglial cells, and pretty much every organ has CD4 positive cells. By contrast, the SARS coronavirus has spike proteins with a receptor binding domain that interacts with the ACE2 receptor. And these receptors are also widely distributed in many cells across the body. I have always felt that HIV transformed the field of virology. And there are many ways to show that. This is simply one of them. What I'm showing you on this slide is the fact of how the times from the identification of the first case to the isolation of the virus has changed over the years. While the first case of HIV was identified in 1981, it wasn't until 2 years later in 1983 that the virus itself was isolated. 20 years later, when the initial SARS pandemic occurred, it took 2 months to go from the identification of the first patient to the isolation of the virus. Contrast that with SARS coronavirus 2, November, December, you have your first cases, and literally the genome's published 2 weeks later on the internet. So clearly evidence that every time I see these pandemics, we learn a lot and we advance science quite considerably. Transmission. We all know of HIV as a sexually transmitted disease that can also be transmitted through injection drug use by sharing needles. On average, an HIV positive patient will infect 2 to 3 others. The R0 or the RT is an inherent property of the disease, also called the basic reproductive number. By contrast, SARS coronavirus is a respiratory virus. And we use the term respiratory transmission rather broadly. We know that respiratory transmission includes large droplet transmission, which is the predominant way in which SARS-CoV-2 is transmitted, but also airborne transmission. And sometimes I think in our mind, we think of these as dichotomous and that you can't have one with the other. Clearly, SARS-CoV-2 has taught us that that's not true. And that is evident in the increasing basic reproductive number of SARS-CoV-2. The ancestral strain, on average, 1 person infected 2. The Alpha variant, on average, 1 person infected 3. Delta moved up to 5. And with Omicron, I've left the number as greater than 6 because literature is still debating it, including some figures as high as 10. So you can see the escalation in the average number of people that get infected as the potential for airborne transmission increases with these strains. The predominant impact of HIV was really felt in Africa. By contrast, the predominant impact of COVID-19 has been felt in Europe and the Americas, both North and South America. Many of you are familiar with the statistic that life expectancy in the US decreased by 2 years as a consequence of the COVID-19 pandemic. I would like to remind you, at the height of the HIV pandemic, life expectancy in Africa decreased by 2 decades, 20 years. Just to compare and contrast the impact of these 2 pandemics through the times. Why is it? Why is it that disproportionately the HIV pandemic affected Africa, SARS-CoV-2 pandemic or COVID-19 pandemic is affecting Europe and the Americas? And one potential explanation is through the understanding that the age groups affected by these 2 pandemics are dramatically different. HIV is a sexually transmitted disease. The age group dominantly affected is between the 20s to 40s. COVID-19 has really affected our elderly, and the age group that predominantly affected is greater than 65. The population distribution of the continents is very, very different. Europe and the Americas in general, especially North America, have a larger proportion of the older population compared to Africa, which is predominantly a much younger population. That is one potential explanation for the difference between the impact of these pandemics on the different continents. Here are the numbers in terms of the numbers of people affected. Remember, we've been dealing with HIV for the past 40 years. We no longer think of it as a pandemic disease. We think of it as an endemic disease, much like syphilis. It has affected 100 million people and caused 40 million deaths. In the United States, HIV accounted for 700,000 deaths over the past 40 years. Contrast that to COVID-19. Globally, COVID-19 has affected over 500 million. Many feel this is a gross underestimate and has caused more than 5 million deaths, or approximate 1% fatality rate. We have clearly not done a very good job of this public health disaster, as can be evident by the number of US deaths within the last 2 years from COVID-19. They have already exceeded the deaths from HIV over the past 40 years. How do we keep in perspective the number of fatalities from a pandemic? And I just want to give you an example of deaths from historical pandemics over the years. 1500 years ago, the Justinian plague ravaged Europe and caused 50 million deaths. 500 years ago, smallpox pandemic through the Americas caused 23 million deaths. The 1918 influenza pandemic that most people compare COVID-19 to caused between 30 to 50 million deaths. And you can see that HIV is right in there between the 25 to 50 million death number. So this gives us a sense of the pandemics, their fatality rates, the number of people that die, and we can compare that to COVID-19, which currently stands at about 5 million deaths globally. I want to pivot to natural history and compare and contrast the two from this perspective. The typical course of an HIV-infected individual is that 6 weeks after exposure, they have a primary viremia in which all the CD4 positive cells in their body are potentially seeded by the virus. This is then followed by a relatively long clinical latency phase in which viral replication is predominantly in the lymphoid tissue and is marked by a progressive decline in their circulating CD4 count at an average of 100 CD4 count decline every year. So if healthy, normal persons have a CD4 count of 1,000, the average lifespan of a patient with HIV is about 10 to 12 years. When your CD4 count declines below 200, we define that as AIDS. You progress on to development of opportunistic diseases, malignancies, and death. HIV is a state of progressive immune deficiency due to uncontrolled viral replication in its natural history. By contrast, COVID-19 is a much more acute disease process where most people will be asymptomatic. We forget that this is not uncommon with many infectious diseases. The ratio of asymptomatic to symptomatic for COVID-19 is estimated at 5 to 10 to 1. Of those that are symptomatic, most will have mild to moderate illness. Mild illness, mostly fever, cough, loss of taste or smell, without shortness of breath. Moderate illness, you will have some features suggesting a lower respiratory tract infection, but oxygen saturation is maintained. In some patients, disease progresses on to a hypoxemic state requiring hospitalization, and in some, critical illness when you need ventilatory support and have multi-organ dysfunction. We know now very clearly that viral replication is high and much, much earlier in the disease process. It rapidly tapers up. Most people, by the time they are in our intensive care units, do not have ongoing significant viral replication. What has happened is that the viral replication has triggered an inflammatory state, which then causes hypercoagulability as well. Death from COVID is not because of ongoing viral replication. Death from COVID is because of an uncontrolled inflammatory response that was unmodulated and failed to turn off. Once we understand this natural history, we can quickly understand that our antivirals need to be given early, first 5 days. Our monoclonal antibody therapies, again, need to be given early in the first 10 days. Very few of these have effect once you get into the severe illness or critical illness. The mainstay of our therapeutics in this stage, where patients are hospitalized, are our anti-inflammatories or anticoagulations. Let's put some numbers on this. If I take 100 symptomatic patients with COVID-19, 80% will have mild to moderate illness and will not require hospitalization. 20 of those will need some hospital stay. Of these 20, about 5% will be in our ICU, from which we get our 2% case fatality rate. Or another way to look at it is 2 out of 20 is a 10% hospital fatality rate. If you look back at the numbers of patients we saw at Ruby and the numbers that died, our hospital fatality rate is about 15%, which makes sense. We are a tertiary referral center. We saw a lot of patients referred in. Now, it is very interesting to note that this natural history held true for the Alpha variant as well as the Delta variant, but has been significantly altered by the Omicron variant. What do I mean by that? Instead of an 80% mild to moderate illness, that number is 90% or higher. Of the 10% that require hospitalization, that proportion is disproportionately those that do not require ICU stay. And for the first time, we're talking about a variant with a much lower case fatality rate. So that's the difference between the Omicron variant and the natural history with the ancestral strain, the Alpha variant, and the Delta variant. Let's talk about prevention. The fundamentals of prevention for HIV are based on this concept of treatment as prevention. U equals U stands for undetectable equals untransmissible. If every HIV patient knew their diagnosis, was linked to care, prescribed an antiviral, took their medication, and became undetectable, you would stop the pandemic. Obviously, other preventative tools like condoms, as well as pre-exposure prophylaxis, not only with orals, but now also with injectables, are the other ways in which you can prevent HIV. SARS coronavirus 2 prevention strategies mainly revolved along our non-pharmacological interventions of masks and social distancing. And that was the only few tools that we had in the beginning. Monoclonal antibodies as prevention came in, especially for those that are immunocompromised and do not have the ability to respond to the vaccines. Treatments. For HIV, combination antiretroviral therapy was transformative. Many of us that took care of these patients talk about 1995 being the Lazarus moment when our first therapies were introduced that were so effective, you literally saw your patients get up off their wheelchairs or get up off their gurneys and be able to go back to work. SARS coronavirus therapeutics have mainly been on the inpatient side with dexamethasone and other anti-inflammatories. The use of monoclonals certainly has a role early in the disease to prevent hospitalization. And now we are finally beginning to see antivirals, not only the IV remdesivir, but also oral antivirals, which should hopefully impact therapeutics of COVID-19. Vaccines. Vaccines for HIV have been elusive. I recall how we got taught at the beginning of our fellowship that by the time we'll finish our fellowship, we'll hopefully have a vaccine. It hasn't happened, and that's been a big challenge for HIV. By contrast, SARS coronavirus, in my opinion, has led to a transformative mRNA vaccine platform. Our traditional vaccines were based on subunits, were based on viral vectors, and at least from my perspective, I think this is going to be a very transformative platform in the arena of vaccinology. Let's talk about variants. We hear a lot about variants when we talk about COVID-19, but what I would like to introduce here is the concept that variants are nothing new in virology. When we were taking care of HIV positive patients in the late 1990s and early 2000s, our main antiviral was a one pill combination called Atripla. It was an efavirenz non-nucleoside based reverse transcriptase inhibitor that was extremely effective. That was our starting regimen. We started on all our HIV patients. For those patients that did not have good adherence, they would select out a variant or a mutation identified as K103N, meaning at the non-nucleoside reverse transcriptive inhibitor gene, the amino acid K was replaced by the amino acid N. And this was significant. This was clinically significant because these patients would break through. Their HIV would no longer remain under control, and you had to go to an alternate regimen. This was practice changing. Guidelines came out saying that before you start antivirals, you need to get a genotyping to make sure your patient's virus does not have K103N. So variants are nothing new in the field of virology. SARS coronavirus has had a number of variants. Some have disappeared regionally. For example, the Beta variant. We don't talk about it much because it was a variant that emerged in South Africa, caused a major pandemic, a major epidemic there, but never became global. The three that have become global are Alpha variant, which started out of Europe, United Kingdom, the Delta variant, which started out of India, and the Omicron variant, most recently, that started out of South Africa. What's the lesson here? This is a global community. If we don't have equitable vaccine distribution and good viral control globally, this phenomenon will continue. And you saw that the basic reproductive number, or R naught, increased from Alpha to Delta to Omicron. Not only did that happen, but another phenomenon that occurred was the mean generation time, the time it takes for one infected person to infect the next, also kept decreasing. So with the Alpha variant, on average, one person with COVID-19 would infect somebody else after 5 to 6 days. With Delta, that became 4. With Omicron, that became 3 days. So you can see that variants are something that occur in most viral pandemics. Why is it? Why do these variants emerge? And that is nothing but natural selection. You have to go back to Darwin's theory of evolution to understand this concept. Natural selection is the differential survival and reproduction of organisms as a consequence of characteristics of the environment. Let's break it down. Evolution is nothing but diversity plus selection plus time. Diversity meaning every time a virus replicates, it has an error rate. We know that error rate. Some of those, quote, mistakes don't go any further. Some get selected out. Selected out because of what? Environmental conditions. The proportion of the population that's vaccinated. The ability of the virus to be more transmissible. And then all you need to do is apply time to this. Duplication times for viruses are way, way, way faster than the time we think of when we talk about primate evolution and others. But variant selection is nothing but Darwin's theory of evolution playing out in real time. We knew about this with HIV. Variant selection occurs when there is a permissive environment. In HIV, I know that if a patient has a viral load of 30,000, every possible mutation will arise once a day. So if we allow for a community transmission or a permissiveness environment in which there is a lot of circulating virus, you will continue to see variant selection. So if at a viral load of 30,000, it takes 1 day before a mutation arises, if I can get my HIV patient under control, undetectable, it's going to take 10 to 20 years before any mutation arises. And that's an interesting and important principle to understand in virology. Let's compare and contrast the two epidemic or two pandemic curves. Let's start with the HIV pandemic curve. It follows what looks like a normal distribution. The HIV pandemic, focus on the red line. This looks at the incidence rate of new HIV infections. It peaked at around 3+ million in around 2000, and then since then has been decreasing. But note that we still have almost 2 million new infections per year. The death rate from HIV peaked a few years after the peak incidence rate and started declining particularly fast after antiretrovirals became globally distributed. But note that it still is at around 1 million per year. We don't talk about these numbers anymore because it's kind of faded into the background, moved from the pandemic to the endemic disease we think of right now. As we became better at saving lives from patients that had HIV, as HIV became more of a chronic disease model, the number of people living with HIV, surviving, and actually thriving has grown quite significantly. Contrast that to the COVID-19 pandemic. So let's look at the bottom first. The timeline here is January 2000, spanning through January 2001 on this side, and all the way to the end of last year and encroaching upon the first week of 2022. I'm sorry, this is 2021, 2022. Let's focus on the colored bars for a second. That gives us the total number of cases. We know that the initial pandemic was ancestral variant. Last time this year, we were dealing mostly with the Alpha variant surge. Again, yellow bars are Americas, green are Europe, the dominant continents affected. Around April is when India went through its outbreak with the Delta variant. And you can see that Europe and the Americas were not as affected at that time. The Delta variant quickly became global, and that was our summer surge, August and September, both in Europe and in Americas. And now comes the Omicron variant. And you can see disproportionately how high those numbers of cases are. Makes sense, right? The basic reproductive number has gone from 2 to 3 to greater than 6. The mean generation time it takes to infect the next person has gone down from 6 to 3. Now, what is very, very interesting is look at the death curve up here. With each of these peaks, we saw significant rises in deaths, but that globally has not been seen with the Omicron variant. From my perspective, one way of thinking about this is this a pandemic in transition to the endemic disease that HIV did? Is this becoming less of a lower respiratory tract pathogen and much more of an upper respiratory tract pathogen? And some of our basic science supports that because we know that the Omicron variant is much more replicable in the upper airways than in the lower tract. I wanted to understand better why these curves are so different. For that, we need to understand what the epidemic growth rate is of a pandemic. It's a simple mathematical formula. R0, basic reproductive number, -1 divided by TG, which is the mean generation time. And we'll plug a few numbers here just so that we understand this. Now, the epidemic growth rate talks of the rate of change in the number of infections. And that concept is a little harder to put your head around. So we will use doubling time. I understand this much better. How long does it take 1,000 patients to become 2,000 patients, right? Doubling time. And that too is a simple mathematical formula, natural log of 2, which is a constant 0.69 divided by R, the basic epidemic growth rate. All right, let's plug in some numbers. This is HIV. HIV, basic reproductive number 2, on average, one person with HIV infecting the next person is measured in days, 150 days. So when I plug these numbers in, my doubling time for an HIV pandemic is about 100 days. One HIV patient infects, becomes 2 after 100 days, 4 after another 100 days, and 8 at the end of 1 year. And then you can begin to get a sense of, oh, this is a slower pandemic. I have always felt that a lot of what I'm seeing with COVID-19 is a very fast pace of the HIV pandemic. It's almost like a decade of HIV is 1 year of COVID-19. Let's plug in COVID-19 numbers. This is the ancestral COVID-19 strain, R0 of 2, mean generation time of 5 days. It took 5 days for one infected person to infect the next person. How long does the pandemic take to double? 3.5 days. By the end of a week, you have twice gone over those numbers. What about Delta? Same numbers, R0 of 5, mean generation time of 5. I didn't change this, even though I've told you that that went down to about 4. Within a day, the Delta pandemic was doubling. I'll let you do the math with Omicron yourself, and you'll be quite surprised to see that the Omicron variant pandemic actually doubles, triples within a day. That gives you a sense of this escalating, very rapid sine wave pattern to these pandemic waves. So doubling time for HIV is measured in months. Doubling time for SARS coronavirus is measured in days. And with the Omicron variant, less than a day. Why is the basic reproductive number important? It's because it also gives us a sense of what proportion of the population needs to be immunized to prevent the pandemic. If we had 100% effective vaccine, we would need to vaccinate this proportion for diseases with these R0. So I've given you examples of pandemics here like Ebola, COVID-19, 1918 influenza, SARS-CoV-2, polio, and measles. Here are their R0s, basic reproductive numbers. Measles has the highest that we know. And if I use these higher numbers, this is the proportion of the population that needs to be vaccinated or immunized with a near 100% effective vaccine for that pandemic to be controlled. I put this number here just to help us think. It is very hard to get to an 80%, 83% vaccination rate voluntarily. And then you can begin to think about why is it that public health uses mandates to try to get to these high vaccination rates. Life lessons. So this is the reflection piece for myself. And many may have gone through these pandemics and have different life lessons. I remember in March, April, we were struggling to just keep up with the publications and the understanding of COVID-19. I remember requesting Dr. Feinberg, please keep an eye on the literature and give us weekly reports and presentations on the biology of the disease. I thought the biology was the challenging part to understand. It is not. In most pandemics, and we saw this with HIV/AIDS, we've seen this again with COVID-19, it's the psychology and the ideology behind these pandemics that are way, way, way harder. I divide the psychology and ideology piece into two components. One is fear and stigma. HIV positive patients bore the brunt of the fear and stigma. The cartoon here depicts which can be transmitted by casual contact, AIDS or AIDS hysteria. Fear and stigma was there even with COVID-19. I recall walking down hallways where if somebody coughed, you looked at them differently. You wondered, would you get infected? So there is a natural psychology to these pandemics that we need to understand. There is also an ideology. COVID-19 played out this ideology. The tussle between individual freedoms versus societal responsibility. Just like I see teaching and learning as flip sides of the same coin, I see individual freedoms and societal responsibilities as flip sides of the same coin. Where you land defines your behavior as either selfless or selfish. How do we think about fear and stigma? And I want to frame this from the perspective of contagion. I've shown you this slide before, the basic reproductive number and vaccination rates. I think that's how we need to think about fear and stigma, fear and hysteria. It is a learned behavior. It is a contagion that's transmissible. I would argue for you that fear has an R0 of 707 and needs literally global immunization for it to be prevented, which is near impossible. Why 707? That's the average number of Twitter followers per account. Just to frame it from the perspective of one way of how you can think about the transmissibility of fear and stigma. And it has consequences. The fear of what's in that vaccine and not taking it has a consequence. To quote Plato, we can easily forgive a child who is afraid of the dark. The real tragedy of life is men are afraid of the light. Another important life lesson, disinformation is way, way, way more difficult to manage than information. Science is slow. We are never absolute. We don't always see black and white. We always think there should be margins to correct. And that creates the vacuum in which disinformation spreads. This has been particularly exacerbated by the social media platforms, because now a public servant with decades of experience, with a lifelong expertise, has exactly the same bullhorn as anyone else with the same number of Twitter followers on their account. And this disinformation becomes extremely difficult to manage. The other personal life lesson for me through this pandemic in particular was a self-recognition of implicit bias, which is, if you look deeply within yourself, probably a lot more prevalent. We get taught about explicit biases. We know what to look for explicit biases. We are all products of our own environments and upbringing. And a deep reflection makes you see inherent implicit biases within yourself. Why is it that these two pandemics disproportionately affect minorities? Why is it that the zip code of where my patient lives is a bigger predictor of their outcome than so many other biological factors. And I would argue that if you do a deep dive, some of this has to do with a lot of implicit biases we do carry. Now, I see pandemics from a big picture perspective as catalysts for advancement. We saw that with virology. I gave you the example of how long it took to isolate the virus. Look at what the COVID-19 pandemic has done for virology. We are looking at sewage to identify early what's going on in communities. You have transformed the platforms for detection of viruses. What great steps and advances in virology have come out of this? Vaccinology, messenger RNA platforms to me are really, again, personal opinion, probably going to transform the whole field of vaccinology. These are replicatable, these are easier to maneuver, they are much more malleable, easier to change. So it would be very interesting to see how things play out. We may have a universal influenza vaccine, we may have cancer vaccines coming out of this technology. It's not only the biological sciences that have advanced as a consequence of these pandemics, social sciences have advanced. AIDS taught us advocacy. The red ribbon started, the pink ribbon started, multiple other things, right? We started advocating for these disease states. Our workplace, we are questioning how we work. Do we need to come to office all 5 days a week? Those are important social changes that are playing out. Racial justice is playing out. Like I said, why is it that certain minority populations are much worse affected by some of these pandemics than others? And then at the personal level, life values. What's important? What really do we strive for that we try to achieve at the end of the day? And these are personal reflections again. Why do a reflection piece? Why reflect? Honestly, it's an attempt to educate the heart. To quote Aristotle, educating the mind without educating the heart is no education at all. I'd like to end with some acknowledgements. This response to this pandemic was a very, very good example of the department stepping up and playing its role across this institution and across the state. Led by Drs. Clay Marsh, Hoffman, Ron Pellegrino, they showed us the way in terms of how to coordinate this. Dr. Larfald and Demachki were the operational leaders for us in the department by controlling command center. Dr. Krupika and his hospitalist team, when everyone was afraid of taking care of these patients, they had the volunteers that took over and developed a COVID unit, taught us how to manage these patients, and took care of nursing home patients and helped us keep the hospital functioning. Dr. Sharma, Dr. McCarthy, and our intensivists have borne the brunt of the bad outcomes. These patients, when they end up in the ICU, have very high fatality rates. Dr. Kaku, the ID section, the infection control nurses, Dr. Feinberg and Hoddard through COVID education, ECHO, and the research that has gone on at this institution. Dr. Becky Reese and our ID pharmacists continuously updating COVID treatment guidance and continuing to educate us. Our ambulatory team, Dr. Gannon, Brian Eddy, Bethany Holt, kept our clinics running, developed COVID intensive programs when the hospital was getting full. Rhonda Robinette and our administrative team worked on workplace flexibility and safety, and our education leadership team under Dr. Safka, our associate program directors and the chief residents, kept our focus on continued medical education, resident and fellows education. It is a team, and this was the group that very, very actively participated in helping us get to where we are. I thank you and will be happy to take questions. So there's a question in the chat about the elusiveness of the HIV vaccine. I'll start by saying I'm not a vaccinologist. I try to understand the process as best as I can. I think the error rate in HIV is extremely, extremely high. The virus replicates, producing so many mistakes. It has probably been a challenge to identify what target would be the best to produce a vaccine against. The other problem with HIV is its long-term reservoir. Once this virus integrates within a cell, the T memory cells have about a 90-year half-life. So it's very, very challenging to eradicate HIV. Our current technique for eradicating HIV is literally a stem cell transplant with a delta 32 mutation of the chemokine co-receptor. And that's the only way I have heard of that HIV is currently being eradicated completely. Question about long COVID. Dr. Reese and I started an ID clinic to try to better understand long COVID. Our understanding of long COVID is that it's a very heterogeneous disease. Some patients with long COVID are long COVID because of a consequence of a prolonged ICU state. Some patients with long COVID clearly are extremely incapacitated by the fatigue and significant difficulty, getting up and going. And you can't find anything wrong except very, very low levels of inflammation. So I know we have not yet completely understood long COVID, and I do know that there's a study here at WVU that is trying to better understand long COVID. So I don't know the science behind it enough to comment. The slide on basic reproductive number and vaccination rate raises this question: what is an effective vaccine? How often must one be vaccinated to control? It's a challenge. I mean, it's a challenge. With measles, when you talk about you need an effective population vaccinated at 95% to prevent a pandemic or prevent an epidemic, that's been borne out. New York City had a measles epidemic because vaccination rates dropped below 95%. I don't think you can ever get to 95% voluntarily. It's like saying, 95% will pay our taxes if we do it voluntarily. It's not going to happen. So, I think those numbers, when you get to that 80% and above, you've got to put mandates on the table. Masking, social distances, mitigation in general, would it be better if we opened schools and let herd immunity take place? I started a year ago thinking that that's an extremely bad idea because in my head, it had a 2% case fatality rate, right? So if you talked about herd immunity with the Delta variant, it meant that you had put a death rate that you were going to accept. And I didn't think that was reasonable. Now, with the Omicron variant, if you are telling me, let me trade you a Delta variant with a 2% death rate with an Omicron variant, which is going to surge because it is extremely infectious, but has a much, much, much lower death rate and is dominantly an upper respiratory infection, should we rethink it? And I think as people in science and people in the field, we should start rethinking that particular area. Is the potential 83% vaccination goal include natural immunity? This is a really good question. So here is my statement on natural immunity. Natural immunity is unpredictable and unreliable. What do I mean? If you get very mild COVID, your antibodies are useless. I can't give them to somebody else and protect COVID to somebody else. The best antibodies are among those that survived an ICU stay. So natural immunity cannot be reliably used as a protective method. And that's why it has not been included in the proportion that are vaccinated. Have we ever reached herd immunity from a virus through natural immunity from mass exposure? Have we ever reached herd immunity for a virus through natural immunity from mass exposure? Great question, Dr. Lerfeld. I do not know the answer to that. What about flu 1918? Flu 1918 disappeared. It did not become endemic. Smallpox. No, smallpox was eradicated primarily because it is exclusively a human transmitted disease process, and we had extensive vaccination with a really good vaccine. And that's why it got eradicated. Remember, by the way, COVID-19 is not going to be eradicated. Why do I say that? Not only because it's so prevalent all over the world, but it's also got zoonotic transmissions. We now hear about deer population that have COVID-19. You can't eradicate a disease once it enters into animal populations. Do you think there's a possibility for IV remdesivir outpatient who fit the window period and have minor symptoms? Yes. It's beyond its area of accepted use, but yes, there is a role. It's a logistically difficult thing to do, but theoretically, IV remdesivir given early in the outpatient setting will prevent hospitalization, just like Paxlovid, just like monoclonal antibodies. Do we have good screening tools to isolate and mitigate high-risk patients in the society and let the virus ride to reach herd immunity? Sweden did this experiment, by the way. If you look at the Johns Hopkins website, the two countries I was following very closely were Sweden and Israel. They both have about the same population. They had dramatically different approaches to the pandemic. Israel is a very controlled society. They did everything the way we have done things in terms of vaccination and all. Sweden opened up society, compared their death rates. The number of people that died in Sweden is about 2 to 3 times higher than the proportion that died in Israel. So it comes back to that societal thing. How many deaths is acceptable? All right. Thank you very, very much, everyone. Have a good day.
Thank you.